So there's very convincing evidence in preclinical work that combined therapy, which aims to block both the androgen receptor pathway and the PI3 AKT mTOR pathway, would be very effective for treating prostate cancer. So armed with that preclinical data, we designed a trial. It was a phase 2 trial in patients with metastatic castration-resistant prostate cancer to look at what was then the available anti-androgen, which was bicalutamide, and the mTOR inhibitor RAD-001. So in a standard phase 2 trial, we evaluated the combination, and combination was well tolerated. We didn't see toxicities higher than would be expected with, say, RAD-00 alone, but we were rather disappointed at the response rate. We just published that work recently, and there are a whole list of possibilities of why the response rate was lower than would have been optimal or ideal, including that bicalutamide itself is really not a great anti-androgen as far as potency. We know that now that we have the new anti-androgens in the clinic, such as enzalutamide. Also, there's data that with RAD-001 alone, you can get some activation of AKT from a upregulation at the level above the pathway. So it may be that with better anti-androgen, a drug such as enzalutamide or ARN-509, and maybe a drug like RAD-001, or maybe one of the newer PI3 kinase AKT inhibitors, one of the dual pathway inhibitors, that will get a better clinical response. So the theory remains alive, and we actually have trials in development with our colleagues at Memorial Sloan Kettering as part of a grant that we're doing, looking at ARN-509 and RAD-001 together. And we will continue looking at some of the newer PI3 kinase inhibitors, AKT or dual inhibitors, continuing to look at this approach. So it has not yet been validated, but it remains a very important clinical combination to investigate.